right, I'm going for it. Oh, there I see it. Okay. Hi, my name's Elaine Walsh, and I am a nurse scientist at Seattle Children's, and I'm also an associate professor at the UW School of Nursing in the Child, Family, and Population Health Nursing department. I've been a clinical specialist for about 30 years, although there was a typo in the program. It might have been my mistake that said I've been a clinical nurse specialist since 1911. I'd like to clarify that's not true, but it has been quite a while. My research has focused on nurse resilience, on suicide prevention, and inpatient psychiatry was my clinical home for a long time. I've been working at the University of Washington for more than 20 years and have the delightful opportunity to do some mentoring with nurses at Seattle Children's Hospital. I follow in giant footsteps of Karen Thomas, and I'm very grateful to her for her help, and to Deborah Ridling for allowing me to do this work. I want to start with saying Happy Nurses Week. And I was challenged myself to try to do better with my visuals. Sometimes I have boring slides, so I'm trying to use a few of our nice stock pictures and from Seattle Children's, and I'm also trying to use some pictures from the internet. So we'll see how it goes. I'll start with one of our beautiful kids, Salia, and these are all obviously used by permission, and they're part of our stock program. So our learning objectives, just want to go through those really quickly. Identifying sources for behavioral instruments, describing measurement characteristics of instruments, and then finally listing factors in selecting appropriate instruments to measure concepts in pediatric samples. And this will be a pretty basic overview. So for those of you who are seasoned researchers, hopefully just an overview and maybe some hints about ways to break things down for folks who are more novel researchers. I always like to highlight the professional practice model and Deborah Ridling talked about that this morning in her conversation. It really gave a nice overview, but just want to highlight, we have children and families at the center of the work we do at Seattle Children's. The petals talk about each of the dimensions of professional nursing practice, and then all of this is embedded in the Seattle Children's values of compassion, excellence, integrity, collaboration, equity, and innovation. And so innovation as a value and innovation and improvements as one of the petals is where nursing research fits into the professional practice model. And I want to thank Karen Thomas for locating this great slide. Interesting information about the 3rd century BC that people used their body parts to determine the measurements of things. So span, palm, digit, foot, cubit, and space, that's all based in history. I cannot wait to meet the person whose foot was a full 12-inch ruler, but I probably have at some point. But the purpose of standardizing measurement is really to quantify, standardize, and communicate among each other about what it is we're doing. So, what constitutes hot? Well, I grew up in Southern California, and so what constitutes hot to me might be different from what constitutes hot to someone who grew up here in the Pacific Northwest. I think more about cold for myself. I'm constantly cold until about July. And so being able to say what the temperature is rather than it's hot or it's cold is helpful. Same thing with, think about things like weight. A small adult and a large child, there could be a very small difference between that. But if we say someone is heavy or someone is light or something is heavy or light, if we have some common ground to be talking about that, it helps us to understand our concepts as well. Volume is another one that I think can be confusing, where you say, well, there's a lot of this. Well, if it's a lot of blood, if it's a half a cup, that's a lot. If it's a lot of milk for your cookies, that might not feel like a lot. So by being able to quantify that, we speak the same language. We can communicate across disciplines, across patients, and also across settings, facilities, and countries. So this common measurement really does help us all in many, many ways. What we're trying to do with measurement is really think about making something abstract more objective. And what we just want to do an overview briefly about a couple of the concepts. So we want to have common language, and the way that we speak about measurement can be calling things a tool. We can call call it an instrument, or we can call it a measure. Those are some terms that you'll hear, and they're often used interchangeably as well. There are physiological measures, and a couple examples of that are temperature, oximetry, behavioral measures, self-report, observational by a parent or by another person is often used in pediatrics. There are also coding systems where behaviors are looked at and you make tick marks or check marks or count certain kinds of behaviors. There are also physiological ways to look at behaviors, galvanized skin concepts and things like that. Salivary cortisol can also be used as well. Just want to go over really briefly levels of measurement. And this is all probably fairly familiar to folks, but just as a reminder, nominal is, there's a name, there's no order implied. So that could be something like gender, blood type, measuring those sorts of things, that it's really just being able to put something into a category, not necessarily that there is more or less of something. Ordinal is where we're starting to look at something that can actually be rank ordered, but the distance between the points isn't necessarily equivalent. So it might be things like income, you know, the difference between what would fall into a lower class income and a middle class income and a high class income. There absolutely are tremendous differences between those, and it's not an equivalent distance. We also can think about level of agreement. You know, do I agree with this strongly? Do I disagree with this strongly? Where does that fit? But it's not necessarily graded between, and it's not a specific equidistance between each of the points. In terms of interval, the distance between the attributes actually has meaning. So that would be something like IQ, Fahrenheit temperature, that there are official differences. Ratio is similar, except there is an absolute 0 point. So that would be things like weight, length of time, temperature in Kelvin. There's increased sophistication as we move from nominal to interval data. And when we think about ratio, you can actually meaningfully multiply and divide information. But not all of the concepts that we're looking at, not all of the behaviors perhaps that we're looking at, lend themselves to every single level of measurement. So not only is it important to understand the level of measurement, because that means this is what we can do, this is how we can analyze it, but it also is important that we're matching the question. So to say I have a ratio level scale when I'm asking someone about their gender, it's not appropriate. There is no way to do that, or even interval. It really is just nominal. I've also just noticed that my dog is snoring, which is pretty bad audience stuff here. So I'm hoping you can't hear it, but I apologize in advance if you can. I also want to talk about measurement characteristics. And those are things, and I'll just run through this list quickly and talk about each of these. They're not necessarily in any particular order. And you will see information about scales, about measures. Some of this is reported, some of it isn't. Some of it is more conceptual than mathematical. But accuracy is really, it's kind of like precision, but it's close to the specific value that we're talking about. So if we're trying to measure something, does this do it? If I'm trying to, and I've been helping a little bit with the vaccine clinic. So if you have a 5 cc syringe and you're trying to do 0.3 milliliters, it's very hard to be precise and accurate. Whereas if you get a tuberculin syringe, you're going to be much more accurate and much more likely to get the dose correct. So that's obviously what we do, is use the tuberculin syringes. Validity is measured, does it measure what was intended? So that's where, as we talk more about putting instruments together, what do we agree is a particular concept? Weight, pulse oximetry, things like that are pretty clear. When we start to talk more about how to measure attitudes, values, beliefs, that gets a little bit more complicated. Reliability and reproducibility, which of course I didn't put in order together, but they're very similar and again often used interchangeably. it is something reproducible, and can, under the same conditions, would we get the same result? So we talk about reliability often if we're using people who are rating behavior, for example. If you and I looked at the same videotape or the same person doing something and used a rating scale to talk about, how happy the person looked, or how engaged the person appeared, or how much pain the person appeared to be in, we're reliable if we use the same tool and get the same answer looking at the same situation. So it's rare to have 100% reliability or perfect reliability 1.0, to have that be happening with measurements related to psychological factors, related to things like weight, height. Those are things that we would expect to be more precise and have to a 1.0 reliability. Response time is, it's a concept, and actually it's in here. It could be actually how quickly I could physically do something. But what I was intending when I wrote it here was really thinking about how long it takes to get the instrument done. How long does it take? We have all kinds of data that's interesting to us. We have all kinds of scales. We want to be sure that we are clear about, are we matching what we're doing to what our population can handle in terms of doing research as well. Sensitivity and specificity are talked about together. And we think about specificity, specificity is correctly identifying something when a condition exists, whereas specificity is correctly identifying that someone does not have the condition. So in a perfect world, we have something with high specificity, meaning we catch all the cases, and high sensitivity, meaning that we don't falsely identify something as occurring. And it's always a balance. I do a lot of work in suicide prevention, and we often will say we will tolerate a lower sensitivity, meaning we identify more people who might be at risk for suicide and follow up and screen them, rather than saying that we would want such a, we could tolerate the false positives, so to speak, because we'd follow up with them. Certain kinds of things like diagnosing diseases, you want to be really careful with high sensitivity. You want to make sure you don't miss the people who have something. And certainly with high specificity, you don't want false positives. So we have the risk of missing something. We also have the risk of identifying something that's not happening. So we want to be careful. Something where you're just screening and you're going to follow up and see how the person is doing, and there's no actual label or condition that we're identifying based on that, then having lower sensitivity is not such a big problem, because you can follow up and get a more accurate and more precise look at that. So truthiness, I had to go look up, I have to be honest. I thought it was sort of a humorous point, but it's not. It is actually, it's a concept in measurement, and it's something that can be seemingly true, but isn't necessarily based on facts or actual truth. So it's just something to be aware. Sometimes we believe things, and I think less so maybe as nurses, but we still have these moments where we believe something that's really not based on data. And so we want to be careful when we're constructing instruments or selecting instruments that we are not selecting something based on what we think should be true or we want to be true rather than what is true. So we just want to have good information as we're picking out instruments or developing instruments. And let me see if I can still advance. There we go. With psychological constructs, I'll just talk through these really quickly, but we're really trying to do, and it's harder to quantify an internal state. It's much easier to say, how much does this person weigh? What is this person's blood pressure? What is their red blood cell count? Than to say, how's this person feeling? How are they thinking about something? What is their attitude or belief? So what we have is, with these kinds of measures, we have conceptual definitions. So these are the behaviors and the internal processes that make up kind of this construct. And, I think about something like depression. We certainly have physiologic measures where we could look at, cortisol levels, we could look at hormone levels, we can look at having one of those moments. At serotonin level, look at brain chemicals and things like that. But what we also try to look at is how are people feeling. So the conceptual definition of that could be things like inability to sleep, inability to concentrate. It could be feeling worthless, feeling helpless, things like that. The operational definition is then how do I measure that? So do I measure that by watching someone's behavior? Do I measure that by asking them how they feel? There's kind of a saying in, reporting with self-report measures. People say, well, those can be biased. But I think it's also important to remember that how else wouldn't I be the best reporter of my internal state and my internal feelings? So I think sometimes there's a critique of that isn't quite as fair as it should be. Certainly, there are all kinds of flaws with self-report, but there's also lots of positive and important pieces related to self-report also. Now here I go with my graphics. So far, so good. The perception of research measures, both physiological and behavioral kinds of things, are that they're objective, so that they're accurate, and that they're easy. Well, they can be, but they aren't always. And I think that's part of why we wanted to have this session today, was to just talk a little bit about how complicated measures can be and some of the things that we need to know about them, and that they're not perfect. There are definitely flaws, and it doesn't mean we don't use them. It means that we want to be sure that we're acknowledging what the limitations might be. So methods, we can have people do a survey, or also called a questionnaire. We can have a self-report. Let me tell you what I think about myself, or I can have another report. And with children, we often look at parent report. In the community, we might look at teacher report. Certainly in hospital settings, we might have nurses report or other people on the care team providing some kind of rating or report. We can also get information through an interview, and we can also get information through observation. And those will often be, with observation, will often be some standardized kind of coding system. Interviews are, versus a survey, can be, there's pros and cons, and on some level it's ideal to actually have both. It's not always practical, time-wise or money-wise, but there are some things that people, and certain people, who find it easier to write what they're feeling or saying. Other times it's easier to talk about it. And again, I'll just go back to my years and years of research with suicidal behavior and thousands of questionnaires. We would have some teenagers who would say on a survey, no, I don't think about suicide. And then in person, they would say yes. Now, yes, their situation could have changed, but some of them would actually say to us, it's too hard to write that down. Others, it's pretty clear that they're struggling and they don't want to talk about it. And so I think thinking about what's the best way to capture information, triangulating these methods can be really helpful as well. And then I just went through a little potpourri of different kinds of scales just to, this is not an exhaustive list, but a comparison scale, is it more of something or less of something? Do you like it more? Do you like it less? Rank order might be preference. Which of these things do you prefer? Which of these methods, which of these medications, those sorts of things, which device do nursing staff prefer when they're working with a particular issue? You can tell I'm a psychiatric mental health nurse versus doing a whole lot of ICU time. There are also continuous rating scales where there's one extreme to the other, and where does one fall in there? Things like pain, the most pain you've ever felt to feeling really good, or things like agreeing or disagreeing. Likert scales are helping us measure attitudes, and those will often be scales that will be things like 0 is not at all, 6 is a great deal, and there may be anchoring words in between the 0 and the 6 to kind of help with what those in-between concepts mean. And then there are also visual analog scales, and again, these are often used for pain. We'll have some examples of these in a little while, but where there's more of a pointing to something, and pointing to something either discrete point on a scale, or there's something called a sliding scale where the person actually decides what their choice is in between all the extremes, between the two extremes. So those are just some examples of scales. And a scale is multiple items related to each other. And what we're trying to do is measure an attribute, trying to get a score or some way to quantify something. What we will sometimes also, so it's a composite kind of a measure. When we look at subscales, those might be independent and standalone subscales, or they might include a summary across the subscales. And I think there's just, a couple of examples of some of the work that I've been doing at Seattle Children's is a concept like burnout. The Maslow burnout inventory has 3 scales: emotional exhaustion, depersonalization, and then personal accomplishment. Each of those has its own score, but they do not get pulled together into one score. It's really 3 different dimensions. And then there are profiles where high on one, low on another, medium on a third might indicate something, but there isn't a precise number where you'd say, okay, well, they're burned out or they're not burned out. The professional quality of life is a similar one where you look at compassion satisfaction, look at burnout and compassion fatigue, but there isn't a quality. This isn't like your life quality is high or low or medium. It's looking at these together. Whereas something like the revised children's anxiety and depression scale, you can get a parent report, you can get a child report. It also looks at behaviors on all kinds of different potential psychiatric issues like panic disorder, social phobia, and then all of that is combined into a total score. And there are things called cutoff scores that we'll talk about in a little while, where you say, okay, if this person scores at this or above, it might be possible that they have this particular issue or problem. If they score below it, it's less likely. So those are often really helpful in terms of just getting a general sense of who you might want to follow up with and screen with more extensive and with more detailed and probably more expensive kinds of follow-up. But in terms of the research that we want to do in day-to-day bedside nursing, we really have to decide which of these is the best fit for the question that we're trying to answer. I'm going to talk a little bit about normed instruments. Sometimes they're called standardized instruments, but it's basically a whole bunch of people answer the same question, and then it's scored in a consistent way. Things like the IQ scores, the SAT scores, those are things that are standardized scores. We have lots of other standardized scores related to children's pain, children's behavior, all kinds of things. Used to compare and kind of rank. Usually it will be set into percentile ranks, like the 25th percentile, the 50th percentile, 75th, and that those are based on normed and scores. So the big issue with these, IQ is a huge problem, is what is the norm? What are these things normed on? Well, IQ is a very Western, English-speaking, probably privileged bent. So when we see someone not necessarily performing at a high score on an IQ test, is it that they did not grow up in the Western US or in the Western Hemisphere, or is it that they truly have an intellectual challenge related to something biological or some sort of traumatic issue? So IQ has fallen out of favor a lot for those sorts of critiques, and that's part of the question when we look at a scale in general. On whom was it normed? Things like the Denver Developmental Screening Test, that was a big one when we were in nursing school many years ago. We all had to go do that. And again, it's looking at social skills, fine motor skills, gross motor skills, but with a very Western Hemisphere English-speaking bent. So someone who, quote unquote, passes might fit certain characteristics that we would see as a dominant culture that made up the survey versus what might really be happening in terms of that. So those are just things to keep in mind. And it doesn't mean we throw these all out, but what it means is we want to be really careful, especially about norming and about saying someone falls in a certain area related to a certain situation. I think another example that's not really, well, we can relate to it, certainly as nurses, especially with grad school, is GRE scores, that many people do not perform well on those GREs and do fabulously in school. So a lot of schools, including the University of Washington School of Nursing, have thrown those out. We just don't use them. They're not a good or fair representation of how people are doing. But let's go back to pediatrics again. Sorry, I had my little tangent on recruiting people to go to grad school. But other considerations that we want to think about is scoring of an instrument. So is it easy to score? Is it difficult to score? Is the formula provided? With some instruments, you actually have to send your data back to people to get it scored, to the developer or some company to get it scored, or some of them provide that option. So they can be really nice with complicated scoring to just be able to put your data set into some kind of an uploaded spreadsheet and have them give you back your data with scores. But things you want to think about with that are, how do you anonymize your data? So for example, even if I use the PROMIS scale, which is patient reported outcomes, and I used it for looking at nurses' depression, anxiety, those sorts of traits, feelings. So I had code numbers that had nothing to do with the person, but when I sent them out to the people who score it, I also went back and changed and gave them quote unquote, false scores or identity codes as well, so that I wasn't sending the actual people's codes with them. So you just want to think about that. You also want to think about cutoffs and thresholds, that knowing what is considered when you're in a danger zone or a problem zone. What is a threshold where you'd say someone is over the line in terms of having a condition or an issue, and when is someone considered under? Whenever there's a cutoff or a threshold, I like to be really cautious. And certainly if it's good news, you don't have this disease, you don't have this disorder, that's always wonderful news. But also, even if there's something that's less positive information that might be more disturbing or frightening for people, is always qualifying it with, according to this, it indicates that it might be, rather than saying, well, you've got it, you've taken this depression rating and you're depressed. To say some of the scores on this particular instrument indicate that this person might be experiencing depression is a much more, I think, appropriate way for us to use tools and instruments when we're talking about behavioral measures. Whereas when we're talking about cutoffs and thresholds related to lab values or things like that, we are able to be much more precise and be able to say this issue is happening or this isn't. But we still have to remember that there are times when things are not accurate. It's not 100% accurate. So often we will look at getting more information about those as well. You also want to think about costs. Again, I'm thinking more about psychological kinds of instruments, but there are some instruments like the PROMIS that's free. It was developed by the CDC and it's free to everybody to use it, score it, whatever. There are also the Maslow burnout inventory, for example, is something that's actually rather expensive. It's somewhere between $1 and $2 per administration of the instrument. So if I'm looking at a large sample and doing this at several time periods, it can get kind of expensive. So just remembering that. There's also, with some instruments, and Maslow is one of them, it's a great instrument, it's really popular, but you only get a certain amount of time. You buy the licenses for a certain amount of time. So you just have to be careful with not violating any of those agreements that you've made and deciding whether an instrument is worth the cost. Many of them are, but just knowing what you're getting yourself into. Other considerations, we want to think about modifying items. So if we decide we'd like to do something different, then have I changed the meaning? And I'll give you some examples a little bit later, but just keeping that in mind as well. The other thing we think about when we're looking at measurement is, especially for some of the studies related to behavior, psychiatric, feelings, attitudes, beliefs, looking at seeing what our peers are thinking or feeling about something, where we want to think about when is it appropriate for something to be anonymous, and meaning nobody knows who did it, nobody knows who filled it out, you couldn't, if you had to find out who it was, you couldn't, versus something being confidential. where I, the researcher, could go back and link. There shouldn't be a piece of paper or a screen on my computer where I say this participant said this, but I could put together my code numbers and my names if I had to, and go back and find who said what, or if I want to follow up with someone. Again, I'll just kind of go back to things like depression or suicide risk or things like that. If you have an anonymous survey and someone's told you, or at least it indicates that they're very depressed or very suicidal, are we okay about that? My personal stance is no. It would be hard, but there are certainly plenty of studies that do those sorts of things with different kinds of caveats, providing resources to everybody or providing follow-up to everybody. So there's ways to manage that. But it's just remembering who and what that you could manage with as well. The other thing that we want to think about is in terms of following up. If someone is providing data for you in a survey or other kind of format, if you're going to follow up, they should know that you can follow up. So to say, if we're concerned about your responses, or we routinely follow up, but something where you don't just say, well, I noticed you provided X on your survey and here I am. I think it's likening it to when you go into your provider's office. You can go in and, I filled out my questionnaire and I've answered all my questions. And if they say, okay, Elaine, you said X on X, well, of course, I did this. I knew you were going to ask me about it, and here's the information. Whereas if I say this is part of a study and it's confidential and you're one of many participants, if I were to come back and say, I want to check in and see how you're doing based on some of the responses you gave me, people should know that before they jump into that process. So we just want to keep that in mind. When you're working with young kids, it may be talking more about how you talk with parents and families, et cetera. But I think it's important to think about some of the things that were talked about earlier today in the workshop, that something like what Alex Shook was talking about, the idea of, what is agency and autonomy, and how do we allow younger people to participate in projects and have that autonomy and have that privacy. So lots of questions, not a whole bunch of answers for everything, but I think things that we want to be thinking about when we're using tools and when we're conducting research. Other things that we want to think about are just some design and methods considerations. So, what are you measuring? And I think I always go back to Karen Thomas's point, what's your question? And then breaking it down to, and then how do we measure that? So conceptually, what are we looking at? Does the measure that I've chosen fit with my question? Does it fit with the background? What else is going on? We also want to look at, do my aims fit my measures? So yes, I have this particular question. How am I going to operationalize measuring that? Another thing to think about is trajectory. How often do I want to measure something? And if you think about something like some standardized school testing or things that are not expected to change day to day, maybe that's something that's done annually. Maybe that's something that's done semi-annually, or maybe it's every 5 years. Whereas you might look at satisfaction with patient care. That might change day to day, hour to hour. That might change week to week. But how likely, if we ask someone to fill out a survey or questionnaire, how likely are we that they would do this every single day? Well, they might, but if it's 10 questions, they might not. If it's one question, I always think about the restroom things at the airport. You remember back when we could travel, but there at the SeaTac airport, there's like a little button you push for how clean is this? And you hit the smiley face or the unsmiley face or whatever. And I thought, well, that's not hard. I'm just walking out. I can do that. But if it were, would you fill out a written survey? No way would people do something like that. The other thing we want to just think about is the survey appropriate for the person's age and developmental level? I just want to keep all of that in mind. There may be this instrument that looks fantastic. It's, conceptually fits. It's got great questions. It's information I want to obtain. But the language is such that it's for people who are older or people who are younger, and it wouldn't necessarily fit with my sample. So we'll talk a little bit about that as we continue to move along here. But I think we do want to think about some of these things. Is this acceptable? Are people, whoops, I knew that was going to happen. There we go. There we go. Is this acceptable to participants? Is it something that they're willing to do? Are the questions too personal? Are they too, is there anything that could potentially be offensive? Culturally, we have to be very careful in terms of some things just in certain cultures are not talked about. And remembering that we have to consult with experts, we have to consult with people who have a better sense of how we intervene with those who may have different backgrounds than us as a personal researcher, or even those of us who grew up in the United States, for example. We just want to be sensitive to those things. And that's where pilot testing and getting information can be really helpful. You also just want to think about practical concerns. How many questions are on this? And yes, I have these 5 instruments that look fantastic and I'd like all of this data, but is this too much for a participant? Thinking about how long it might take them to complete this battery of tests. Modifying tools is also something to think about. Have you changed the meaning? Are you doing something that's different? One of the biggest things I encourage people to do, if you say, well, I'd like to ask this question slightly differently, or I'd like to do this, contact the developer and get a sense of whether or not they may have unpublished information and unpublished data where they have more about their tool. So that's something to think about. But minimally, it's also just basically if I were using the Maslow with burnout inventory and I call it that and I don't use those items, that's also misrepresenting. So I wouldn't want to do that either, and nor would I want to change their items, but that was just the first one that came to mind. The other things you can do are your own tool. You can, first of all, it's really important to seek out expert or at least learned consultation. So I've got these ideas. I think these items might represent this. I'm going to talk to other people who have good knowledge of the field and just say, basically, first of all, when you look at these items, does this appear to be measuring the concept that I'm trying to measure? We want to think about reliability and validity. So the reliability piece is, again, does this measure what it's supposed to measure? Is it reproducible? And am I getting good information about what I'm trying to measure? We also encourage people to pilot test, and it may be formal or informal, depending on how grand a scale you're trying to work on. But a couple people mentioned earlier in the day, that when Connie was speaking about her study, that she asked a couple parents to go through and look at measures first. And it doesn't have to be formal, but just having someone who's an expert in whatever that area is, take a look at, is this something parents would be willing to do? We're doing a project, getting started on something on the medical unit, and it's a quality improvement project, but we were able to consult with parents to look at the instrument that we were going to ask them to fill out about their satisfaction with care, and just get a sense of, how long did it take you to do this? Did all these items make sense? Things like that. So I just want to get to that as well. I just put this picture in because I love Charlotte and Beatrice. I don't know them personally, but I love their picture. And I also hope that by now you're not laughing at the presentation or blowing bubbles. So that's why I put that one in there. What I want to do is just go through a few examples of tools, and we'll go through these pretty quickly. This is not an intent to dissect all the tools. It's not an intent to do anything other than just show there are these kinds of tools that are commonly used, mostly in pediatrics in pediatrics. So, something like the Apgar, anyone who's worked with infants, newborns are pretty familiar with these sorts of rating scales where we're looking at each of these items and then coming up with a composite score. What I like about the Apgar also is there's a place for comments. So yes, there's a score, and then we will compute that for gestational age, but we can also add comments about anything we might be observing. Hector Valvidia was featured on Nurse on Child, one of the stories about some of the work he's been doing. in the ICU, and one of the instruments he used was related to pediatric delirium. I see this is a little bit blurry, but the Cornell assessment for pediatric delirium. And again, you can just see from this score, that people are rating, and the rating scale changes 1 through 4, never is 4, and always is 0. Whereas the second set of items, never is 0, always is 4. So those are the kinds of things that, and obviously we want this to come out 0, that the child is not delirious. And so the scoring makes sense, the reverse scoring of the items and things like that. But we also just want to be sure when people are filling these out that and this is usually filled out by a provider or the nurses who are working with the child, obviously. But what we want to make sure is, did they pay attention to that rating scale? Are they looking at the numbers? Are they looking at the words? And so making sure that people know how to fill the scale out is also important. Pittsburgh Sleep Quality Index is just another example. There's some open-ended questions at the top. And then we've got these rated items that go from 0, not during the past month, up to 3 or more times a week. And again, I look at, it's a good instrument. This is just one snapshot of one part of it. But less than once a week is 1, once or twice a week is 2. So again, it's just looking at being careful that people look at the words and what they mean and not just the numbers. Those are pretty logical, but there are some scales that don't quite line up as logically. You just want to make sure that you orient people to that. The FACES pain rating scale, people are probably pretty familiar with this, or at least this type of a scale. This is very, very Western, very, very, do these faces look like our patients? Actually, no, they look like my great-grandfather, I think, sometimes. So not to overly criticize this, but is this the kind of thing that a child who didn't grow up in the US, or a child who doesn't speak English as their first language, that this would be something they could relate to? And how can we do better? And certainly there are many, many pain scales. This is just an example of why this one, could be relatable, but there also could be some problems with that. Glasgow Coma scale, people are pretty familiar with that. It's another one where we're looking at adding up. You've got eye opening, you've got motor response, you've got verbal response, you get totals in each of those domains, and then you get a composite score. Perceived stress, just another possibility to look at. And this is more of a never to very often scale. It's the same scale for each of these 10 items. What we also look at when people do scales like this is that they don't get into a big, I can't gesture, but a big circle. I'm just going to circle the 0 and not even read the items, or I'm just going to circle the 4. So often with a scale like this, there might be something that's reverse scored, so that it's not that someone's trying to deceive us. It's just that people get into a mindset, nope, 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 nope. So something that actually should be reverse scored, so that if they keep putting 0s, it flags us to say, but wait a minute, that actually, if they really had read it, a 4 would be more consistent with where they are. So just keeping those kinds of things in mind, and knowing, I think it's just one more reason that these are tools, but they're not the ultimate and only way to answer questions, and there are flaws with all of them. PHQ-9, we're all familiar with. I pulled this one out because I also, again, with my mental health work background, item number 9, thoughts that you would be better off dead, or thoughts of hurting yourself. We should pay attention to that. If we ask someone to fill out a PHQ-9 and then we don't follow up, I personally feel like that's, we have an ethical responsibility to at least check in with the person or provide resources. And how might someone feel if they answer surveys or they answer questions where they tell us about difficult states and then we don't follow up? So just something to keep in mind as we're using scales. This is a very Seattle children-centric slide, but I think you could replicate that at your own institutions. Just remembering that we have a library, which is fantastic. We have certain databases that we would want to search. We are looking specifically at things like SynHall, which is a lot of nursing literature. PubMed is pretty wide in scope related to what we might term more, or the medical, making sure anything medical journal-wise will be included in there. Some of the psychiatric journals are not included there, but they are found in PsycInfo. But honestly, SynHall is great for all nursing journals. PubMed is good for almost anything, and most of the psych journals land in there as well, but doing a thorough search could include looking at all of those. There are also other databases with other specialties, anthropology, lots and lots of options. And it's really a gift, I think, back to doing research in grad school back in the 90s, you know, where we were in the library in the stacks looking at books and books and books, and now we have this all at our fingertips. So please do use this at your facility, or figure out where you can get access to this. And certainly consulting librarians, I think, is one of the best choices anytime, trying to narrow down, finding information, trying to narrow down how to do a literature search, etc. So where do we go from here? Well, it's a red panda. And I just wanted to put the red panda there. So if you decide to do a research study, first things you want to figure out, what's your question? What is it you want to measure? How do you select instruments? Well, you're going to look at the literature. You can ask a librarian. Also see what others are doing. What are others using? What can we learn from the work of other people? And I just thought we have just a few more minutes, could pop through, and I don't know if it's easier to unmute or if it's easier to do the chat, but I'll let Hyen direct me here. Just want to think about some scenarios. So, of course, it's trash day here, so there's a loud trash truck going by. But what should we consider next? We want to think about the psychometrics. We want to think about what population this work has been done with and normed with. We want to think about language. Translating something to another language is not as simple as it seems. Think about time to complete. So here's some scenarios, and we can either, Hyen, I don't know what is best, pop in and unmute or read me chat, but I'll stop and let you answer.
Elaine, this is Lindsay. We can help you read questions from chat. Let us know whenever you're ready for the question.
Okay, this is great. Thanks, Lindsay.
No worries.
Let's say in this scenario, you find an instrument that addresses a topic you're interested in, but it's only been used with adults. You want to use it with kids. What do you do?
So Elaine, we have one that says contact the developer. Sure, we'll get more. Pilot with kids, review results. I totally agree with that. Quick reliability/validity testing. Find another instrument.
Excellent. Those are all really good choices. And certainly, if there are other instruments, that's probably the simplest thing to do. But sometimes we get into these situations where there really isn't a whole lot else. And how do instruments get developed other than people being willing to say, we don't have this and we need to do it? So again, I think that's where nurses can take the lead and say, okay, we're going to figure out how to do this instrument and how to use it with a different population. Here's another one. Here's an instrument that's available in English, but you want to use it in a study with families who prefer a language other than English. Any thoughts on how you might handle that?
Nothing in the chat yet, Elaine.
Okay, I can go. This is one of my soapboxes, so this gives me an opportunity to go off on a soapbox about regulations that we have to protect subjects that sometimes I think can get in the way. If it's a research study, most IRBs will require a translation, a formal translation and back translation, which can be expensive, but my big issue is it's time consuming. So often we could not include a family in a research study if, let's say, they're only in for 2 days and they speak. We've translated some. We've had something translated into 4 languages, but they don't. That's not one of the languages. That's not their language. The time you can't send it to the IRB, get it back translated, get that all done, and still include the family. So I feel like some of these things get in the way of us making progress. And one idea would be to use an official interpreter to read the items, just as we would with a consent form or things like that. You know, we lighten up a little bit to be more inclusive. I know
Elaine, also,
yeah.
People did add to the chat lots of great things about getting translations or using a translator, like you said. Also doing like validity assessments and pilot study testing that as well. So all great things.
Great. The big answer that I think is so important that we as nurses need to push back on is, how do we include families who prefer a language other than English? That it can't just, okay, well, we can't. And I feel really supported by Deborah Ridling and others at Seattle Children's that is something nursing research is really trying to do, is to support those efforts to be more inclusive. I think we are pretty much out of time. I just wanted to show you my other one. There's no instrument to address your topic. There you are at the beach. There's nothing. So make one up. Just a quick summary. Using an established, validated, and reliable measure is always a nice choice, but if it's normed with a different population, you can't assume it will apply. You can contact the developer. Always check costs. When you use an instrument, regardless of whether it's got data or not, you should report your psychometric properties. Be careful when you're reproducing instruments in publications. Some will not let you. They don't want it out in public domain. You have to pay for it. It's also okay to create your own instrument, and it's more credible if you establish reliability and validity. So we've kind of done questions, but again, I like to show Olivia, and thank you very much.
Thank you so much, Elaine. I think we have one question, which you kind of touched on at the end. I'm asking, are most instruments at a cost? Can you speak to the logistics of reaching out to authors regarding their instruments?
Sure. Actually, there are a lot of instruments that don't cost anything. And one way to find them is actually to do the thing I hardly ever want to do, which is Google. But if you can Google it and find it, it's generally something that's in the public domain. There are some like Achenbach, which is a child behavior checklist, where you can find it, but there's a giant word that says sample across it. So it's very clear that, yes, you can see what the specific items are without paying for it, but if you want to use it, you need to pay. So just keeping that in mind as well. Oh, go ahead, I'm sorry.
I think there's a couple more questions, but we are getting close to the end.
Okay.
I think we could do probably one more. Any recommendations for resources discussing how to test reliability and validity of self-created instruments? Kind of a loaded one.
Yeah, that's a loaded one. We'll have to have another seminar about that. But consulting experts, there are specific procedures for it that you can find in textbooks, and you can also get some support from either faculty or nurse scientists where you are. Yes, absolutely. And there are a lot of instruments that you don't have to pay for. And do contact the developers. Most are very, very generous with allowing people to make changes and allowing people to use their instruments. Thank you all so much. I'm sorry to be rushed there at the end. I always promise myself I won't be that person who keeps you from the next thing. So thank you so much.